Hi, my name is Sudarshan Parthasarathy. I'm a PGY3 resident here at Highland Hospital, and I'm happy to present to you Approach to Acute Kidney Injury. Now, what are the objectives of this brief podcast? To review the definition and classification of acute kidney injury, or AKI, to provide a systematic approach to evaluation of AKI, and to construct a brief clinical approach to AKI. Now, let's go through some definitions first. Acute kidney injury, or AKI, is a sudden, sustained, and usually reversible decrease in the glomerular filtration rate, or GFR, occurring over a period of hours to days. There are more than 35 published definitions in the literature from various organizations like KDIGO, Rifle, or Akin. And a lot of these use surrogates of evaluating GFR, such as urine output or the serum creatinine. And rather than make you memorize one particular definition, I think the most important thing to recognize is that we should all use the serum creatinine and first ask ourselves, what is the patient's baseline? Whenever we look at a patient's chem panel and we see that they have an elevated BUN creatinine and we're consulted about AKI, we should ask ourselves, what is the patient's baseline before considering how to approach AKI. Now, let's remind ourselves a little bit about BUN and creatinine before going further. BUN is synthesized in the liver, and remember, it's filtered and reabsorbed. Meanwhile, creatinine is the end product of muscle metabolism, and it's filtered and secreted. Let's remind ourselves what that actually means. If we took a little diagram of a nephron, just remember, when we think about a flow state, maybe a low flow state, BUN, there's an afferent and an efferent arteriole, is actively reabsorbed here at the proximal convoluted tubule. Meanwhile, creatinine is actually secreted here. So, in this case, whenever we have a low flow state, we have a low amount of filtration, and so your BUN is going to rise. But since it's going through this nephron slowly, it's actually going to rise further because you've got more time to reabsorb in the proximal convoluted tubule. Meanwhile, creatinine, when you have a low flow state, is also going to rise, but it's not going to rise as much as BUN because you only are filtering, you're not reabsorbing, and you're actually secreting a little bit. So in our classic thing that we've all learned in med school, when we learn about BUN creatinine ratios, in a low flow state, BUN rises much more than creatinine. So you learned that it's usually like 20-1 in a pre-renal state, whereas in an intrinsic renal state, it's like 15-1. The other small point I want to bring about on this example of a nephron is that in the proximal convoluted tubule and elsewhere in the kidney, you're reabsorbing sodium. And whatever follows sodium is usually water. And it's important to recognize this fact because, again, when you're in a low flow state, your kidney senses this and is going to want to hold on to as much salt as possible. So in a low flow state, what's going to happen? You're actually going to see that your urine sodium is going to be less than 20 because you're holding on to it as much as possible. And as we mentioned, water follows salt, so that's going to mean that your urine osm is going to be what? It's going to be high. And just to remind ourselves, what's the definition of osmolality? It's 2 times sodium plus BUN divided by 2.8 plus glucose over 18. Now, let's construct a brief differential diagnosis of all the causes of AKI. And we can conveniently think about this as pre-renal, intrinsic renal, and post-renal. And in pre-renal, think this is a diagram of your heart. Think CHF or MI. If you have a CHF or an MI, you're not pumping blood to the kidney. These are all low perfusion states to the kidney. Think about anything that can give you hypovolemia. So imagine if this was a tank sending blood all the way to your kidney and this spills out a whole bunch of blood. Think hemorrhage. Think burns. Think massive vomiting or diarrhea. Also, consider medications. I'm not going to go into which medications affect which part of your kidney, but you can think about things like ACE inhibitors, think ARBs, think NSAIDs, cyclosporin, think aminoglycosides. Those are some classic examples. You can also think about, rather than just massive loss of blood or thing, you could think about third spacing. These happen in states like cirrhosis, or easy way to remember it is nephrosis. So in cirrhosis, you're obviously not, you're in a low albumin state, so you third space a lot of fluid. And in nephrotic syndrome, you're actually losing protein in your urine. So these are the two classic examples of third spacing that are involved in pre-renal. Now, intrinsic renal, and depends on which system you use here, but think about renal artery stenosis. This is your renal artery coming into your kidney. You could think about an old man, renal artery stenosis with a lot of atherosclerosis. Or if you think a young female, you could think of fibromuscular dysplasia. That's getting into your kidney. Now, before we go to intrinsic renal, let's think about anything that could cause acute AKI that's post-renal. This is after the kidney. So obviously you can have a bladder outlet obstruction from a stone, or think an old gentleman who has BPH. You can get a stone anywhere. You can get it along here. These are the ureters. This is in the bladder, so you can also get malignancy or stones anywhere along here. You can also get retroperitoneal fibrosis. So any of these things can actually cause post-renal AKI. And the simplest way to evaluate this is stick a Foley catheter. The Foley catheter should go in the bladder. And if you get a post-obstructive diuresis, you kind of know your answer. You could put your ultrasound over the kidney here. And if you see that there's hydroureter or hydronephrosis, water around the kidney or around the ureter, you know that this is likely post-obstructive renal. Now, let's think about intrinsic renal. So as I mentioned, if you get a low perfusion state to the kidney from any of these things, you now could potentially get your tubules here, anywhere along here, to slough off. And so pre-renal can actually become ATN. So this is actually where your tubules become necrotic. And we won't go through a lot of the different causes, but just it's important to think about, when we think about intrinsic renal, to think about casts. So we're going to look at the urinary sediment. If the actual tubules get damaged, you're going to get muddy brown casts. And that's what you get in ATN. If you damage the glomerulus here, you're going to get RBC casts, and you're going to get glomerulonephritis. Now, here's the interstitium, and if you have a problem with, if you see WBC casts in the urine, you're going to think acute interstitial nephritis. So that gives us a brief differential diagnosis to consider: pre-renal, intrinsic renal, and post-renal. And finally, let's come to basic indices to evaluate acute kidney injury. So in pre-renal, consider a ratio of 20 to 1, as we mentioned, whereas intrinsic renal will be less than 15 to 1, right? And this goes up because BUN is both actively filtered and reabsorbed, whereas creatinine is actively filtered but not reabsorbed, and it's actually secreted. We could think about something called specific gravity. This is kind of a surrogate for how to think about your kidney concentrating urine. So in pre-renal, it's going to be greater than 1.010 or 1010, the 1010 rule. Whereas here, if you have damage to the kidneys, it's going to be about 1.010, 1010. Now, we mentioned that in a low flow state, pre-renal, you want to grab onto as much sodium as possible, so urinary sodium here is going to be less than 20, whereas in intrinsic renal failure, you're going to think about, since your tubules are not working, your urinary sodium is going to be greater than 40. And the FeNA is another way to kind of express this, and this is just how much is filtered divided by how much is excreted. So if your urinary sodium is low in pre-renal states, your FeNA is going to be low as well. So this is usually less than 1.0. And in intrinsic renal, it's the opposite scenario. Your tubules aren't working, so you're unable to reabsorb the sodium. So your FeNA here is going to be greater than 2.0. And now we talked about how whenever we have reabsorption of sodium, water follows it. So if you are grabbing as much sodium as possible, you're also doing the same thing with water. So here your urine osmolality is going to be greater than 500, and in intrinsic renal it's going to be less than 350. And remember, urinary sediment only happens when you damage the intrinsic part of the kidney. So here your urinary sediment is going to be bland actually. Whereas in intrinsic renal, your urinary sediment is usually going to tell you what type of injury you might have to your kidney. If you have an RBC cast, you're going to think glomerulonephritis. If you have a WBC cast, you're going to think of a acute interstitial nephritis. And if you have muddy brown casts, you're going to think ATN. And remember, we can always think about AKI by using these indices for pre-renal and intrinsic renal. If you think this is a post-renal syndrome, put your ultrasound on the patient's kidney and put a Foley catheter, and if you get post-obstructive diuresis, you have your answer. Thank you.